This video demonstrates right hepatectomy using anterior approach for a large right lobe hepatocellular carcinoma. When we try to mobilize the right lobe with a large tumor, there is a high chance of tumor rupture or vessel eversion. So such tumors are operated using the anterior approach without mobilization of the right lobe of the liver. This 40 years old gentleman had abdominal pain, and on investigation he was found to have a large liver tumor. His liver function test, viral markers and tumor markers were negative, and his triphasic CT scan showed an 18 centimeter tumor in the right lobe of his liver without portal vein thrombosis or metastasis, and there was no portal hypertension and there was no ascites. So this is a CT scan. You can see there was a large tumor in the right lobe of his liver, almost occupying all the segments of the right lobe. There was no involvement of the portal vein or hepatic veins, and the left lobe volume was adequate. A Mercedes-Benz incision was kept and the abdomen was explored. The cholecystectomy was performed and a catheter was inserted in the cystic duct. As you can see, the hilum was approached. The bile duct, right and the left hepatic artery, and the right and the left branch of the portal veins were dissected and slinged. An umbilical tape was passed for the Pringle maneuver. As it was impossible to mobilize the right lobe, we decided to go for an anterior approach. The parenchymal transection was started using the monopolar and bipolar diathermy as well as using CUSA. The smaller pedicles were clipped and divided. The larger pedicles were ligated and divided. Now at the hilum, the right branch of the bile duct was divided, and then the right branch of the hepatic artery was divided. Finally, the right branch of the portal vein was dissected and clamped. This is the right branch of the portal vein which was clamped and divided. The right portal vein stump was closed in 2 layers with the help of 5-O-proline. An intraoperative ultrasound was performed at a different stage during the procedure. Parenchymal transection progresses further and cranially. You can see now the liver is open like a book without mobilization of the right lobe. So this is the area in front of the IVC. This is the divided caudate lobe, and that is the IVC. Transaction progresses further and cranially towards the right hepatic vein. The infrahepatic peritoneal attachments close to the IVC were divided, and the space was created to mobilize the inferior part of the right lobe of the liver. And the right lobe of the liver was further mobilized, and the IVC, you can see, was slowly exposed. Now a large clamp was applied on the right hepatic vein, and it was divided. After dividing the right hepatic vein, the further mobilization of the right lobe was done to remove the specimen. You can see the right lobe of the liver was now mobilized finally to remove the specimen. So this is the large specimen of the right lobe tumor. Now the right hepatic vein orifice was closed with the help of fluoroproline in 2 layers. Finally, the intraoperative ultrasound was performed at the end of the procedure, and a methylene blue test was performed to see for any bile leak. A small bile leak was sutured. So this is the final picture after the resection. You can see a large left lobe of the liver which was normal, and this is the hilar area, this is the IVC, that is the right hepatic vein, and that is the area where the tumor was lying. Thank you.